Okay, how's it going? My name is William Shivani, and I will be giving my presentation on enteral feeding tubes, specifically nasogastric tubes versus nasoenteric tubes. So to begin, um, what are the differences between the tubes and what are the tubes? So a nasogastric tube is a tube that goes from the nostrils or the nose down into the stomach, as opposed to an any tube, nasoenteric, which goes from the nose to the small intestine. So the main difference between the two is where the feeding takes place. Um, Specifically, this depends on the GI function of the patient. If their stomach works, then you should use an NG tube. But if the stomach is a problem and we need to pass through the stomach, then ideally, well, not ideally, you should be using an NE tube. Um, Again, it's dependent on GI function. And typically, the typical lifespan of either of these tubes is no greater than 6 weeks. Okay, so picking a tube. Um, so um, as you see here, a small bore tube is defined as 8 to 12 French gauges. What is a French gauge? Great question. A French gauge is the size of 0.33 millimeters. So 8 to 12 millimeters times 0.33 millimeters equals the diameter of the tube. And primarily, a small bore tube is used when the patient is in discomfort. Um, to further explain, a large bore tube is anything greater than 8 to 12 FRs. The benefits of a large bore tube is it can provide more formula and an overall increased flow rate. However, um, anything within the nose can irritate the patient. So the smaller the tube, the less irritation, but less flow, less formula that can be delivered, and more risk of clogging. So, how you decide? Well, it depends on the patient's comfort tolerance to the tube feeding. And then there are three main methods of bedside tube placement. There's a couple more, but there's three main categories. So the first is a blind placement technique. And this involves inserting a tube without any visualization of the tube um, and works the tube through the nose down to the desired portion of the GI tract. So, this is the standard hey, they need a tube feed, let's put a tube in their nose. It uses no technology other than just someone putting it in. And typically, tube placement is relatively safe. You'll know if, well, you won't exactly know, but the patient will probably tell you if there's extreme discomfort or if they feel something is wrong. So typically, a blind placement technique does work. However, there are also other techniques that work too. The next one is direct visualization. So visualization allows for the tube to be seen as it enters the GI tract. This is done through methods of endoscopic or camera guided technology, meaning um, that there is a camera uh, inside the tube or um, a camera outside looking into where the tube is going and can directly guide you to where the tube needs to end and finish. That is obviously a much better method, however, is also a more costly method and takes much more effort than simply a blind placement technique. Um, the last technique is a indirect visualization. This allows for real-time tracking or indirect visualization of the tube as it is as it is being inserted into the GI tract. This is done through methods like fluoroscopy, an ultrasound, or even electromagnetic guidance. So overall, those are three main techniques that you can use to place a tube, and it all depends on your hospital, what type of materials you have at your disposal, budget, things like that. I'm sure your specific hospital has methods in place, and those typically work best for that hospital. These are just alternative methods, or maybe this is your method. And then for tube insertion, how do you place a tube? Well, typically, the NG tube can be placed by a dietitian, or more often, it is placed by a doctor or nurse. Usually, the procedure is done in a hospital, while there are instances when a doctor may need to put you to sleep to place a tube. However, it's very rare, very uncommon. I shouldn't say rare, more uncommon. Most people are awake during the procedure because it doesn't cause pain, but it may cause discomfort, which for some people they can't do, which is okay. You'll just need to you need to have them be put to sleep just so you can get the tube in place. So how do you place a tube? Well, first, um, the nasal area should be numbed with either lidocaine or anesthetic spray. The NG tube is usually coated with lubricant gel to help it go down easier. Obviously, you would like to lube up the tube before you place it because it just leads to less discomfort for the patient, which is the ultimate goal. Um, the NG tube, after it's lubricated, is then inserted through the nostrils, down through the esophagus, and then eventually into the stomach or small intestine, wherever you need to place your tube. And typically, while this happens, whoever is placing the tube will have the patient swallow while it's being placed. It is uncomfortable, but it shouldn't be painful. And if you do feel pain, that is a sign that the tube is not placed correctly. And then for tube verification methods, essentially what these are is once you put the tube in, perhaps the patient doesn't experience any discomfort. That doesn't mean the tube is incorrectly. It still could be in the wrong place. So how do you know? There are multiple ways of verification methods. With the first being X-ray. This is the gold standard. Using an X-ray machine can allow for images um, to see where the tube is exactly placed, as evidenced by our cartoon right there. Using that would be very beneficial. It's also more costly, and typically placing a tube is safe. But if you do have the funds, budget, and utilities to use an X-ray, that's typically the gold standard. The next verification method is a pH test. Small amounts of gastric fluid are drawn and they are compared to typical pH ranges of gastric PI to test if it was pH to test if it was placed properly. So essentially, we're comparing pH to pH, and if it's increased or if it's decreased or there's a specific range. But if it's at that specific range, you know that the tube is working fine. The next method is capnography. This is a calorimetric CO2 detector. It is used during placement. If CO2 waveform or a color change is revealed, we know the tube is misplaced. This is more advanced, but again, it's still a verification method. The next method is the EMPD. The tube feeding itself has a specialized transmitting stylet with the receiver placed on the patient's abdomen. The tube can be viewed on a monitor for placement to ensure effectiveness. So essentially, the transmitting stylet and the receiver placed on the patient's abdomen, there is a tell, and you can see on a monitor that they should line up. If they do, your tube is placed successfully. Next method is an ultrasound. It's not the most effective, but it is cost efficient. Or it's not cost efficient. It's cheaper than an X-ray. If you don't have an X-ray but you have an ultrasound and you don't have any other methods, you can use an ultrasound. But an ultrasound has been shown that it can find a misplaced tube. And lastly, direct visualization. The use of a camera or device similar to a camera, which you can use to physically see the tube. And all of those methods can be used. Some are better than others. Preferably the X-ray is the number one method, but they can all be used to ensure that your tube was placed correctly. Next, how do we know the tube is secure? Well, there really is no way to, no great way to put a tube and make sure it is secure. The main method to which you ensure that a tube is secured is often tape or nasal tape. And typically tape is placed on top of the nose to physically tape the tube in a still position. I'm sure you guys have seen patients with EN feedings and they have a little bit of nasal tape. It works. So if it ain't broke, don't fix it. However, there are other methods. Um, the next method is transparent dressing. This is where the tube is secured by the clothing worn on the patient, typically like a clamp or any other type of tool, which can little tool, push pin, not probably not a push pin, but something similar to a push pin, which can keep the tube at bay on the patient's clothes. Typically, someone in a hospital bed isn't moving too much, so that is another alternative method to tube securement. There are also other commercial securement devices. This is when the lubricated probes are inserted into each place, and these probes connect via a magnet for filament over the vomer bone to secure that the tube is in place. So essentially, there are also other methods, but one method we found was that uh, magnets together can keep the tube in place and is also a good um, method. And then lastly, it's important to talk about the side effects of enteral nutrition and tube feedings. Typically, they're really not the worst complications. Often, enteral nutrition can save lives, prevent malnourishment. It's a really critical step for a patient in certain settings, and they might not like it, but it's unfortunate that they have to go through it. But it's been proven that it works. So, like I said earlier, if it ain't broke, don't fix it. But some common side effects to be on the lookout for after tube feeding uh, include abdominal cramps, aspirations, diarrhea, swelling, difficulty speaking, and tube dislodgement. It's always important to monitor the patient, how they are tolerating the enteral nutrition formula, how they're how they are handling the tube physically, and it leads to some complications. However, again, the complications I'm sure are worth it. Thank you.